All right, we're gonna do chest trauma and pleural drainage. So, I am recording, thank you. So when we talk about chest trauma, it can go anywhere from like simple rib fractures to life-threatening organ rupture. Traumatic injuries to the chest contribute to 75% of all traumatic deaths. So when we talk about the mechanism of injury on chest trauma, we talk about blunt and penetrating. So what does blunt mean?
A blunt force, like you got here without
it didn't enter. It's closed, like a baseball bat or motor vehicle accident. The steering wheel, your chest goes into the steering wheel. I don't know how many cars don't have airbags anymore, but I'm sure they're still around. So basically it's when your chest is struck by an object. So when you have the blunt, you can have, remember when we talked about head injuries in the brain and we talked about the deceleration and acceleration? So, the same thing happens inside the cavity of your abdomen. Things are moving around. There can be shearing, there can be tearing, there can be all sorts of stuff happening. Even from the outside, it might not look like there's any injury, right? So it can look pretty minor, but really there can be very severe injuries on the inside. What are some life-threatening things that could happen?
Pressure could build up, and it can.
Okay. So if the pressure builds up in your abdominal cavity, what's it called?
In the abdominal cavity, pressure in the abdomen.
It's called the same thing as it is in any of your limbs, right? When the pressure builds up.
Okay.
Compartment syndrome, right? So you can get compartment syndrome. See, I just got to pull it out of you. You got it in there. You can have tearing of the aorta or a rupture of an organ. So penetrating is obviously the opposite. So it's an open injury. So it can be gunshot wounds, knife wounds, rebar. You could fall from a ladder onto the fence. There's many different things that can cause an open penetrating wound in the thoracic area. Yeah. So again, the severity is going to depend on where the injury is and the affected organs and vessels. So a pneumothorax is going to be air entering the pleural cavity. So normally inside our lung cavity, inside the pleural space, it's negative pressure, right? So if we have an area that's open and air is allowed to get in, that's positive pressure. And that's going to cause the lung to collapse. So we don't have that negative pressure holding that lung open. The lung is going to collapse. It can be open or closed. That picture is an open, obviously. So a closed pneumothorax can happen, we can have spontaneous, right? So we have another slide with all the different types on it, but we have little blebs on our lungs. We can get little, they look like blisters, and if those pop, those can cause a spontaneous pneumothorax. But the air still is entering that pleural space. It's just coming from inside the lung instead of outside the body. So what are the clinical manifestations? What do you think your patient's going to look like if they have a pneumothorax? They could have chest pain. What? Tachypnea. Maybe they're coughing a little. What about when you listen? Diminished or absent? So they're going to be absent, right? Diminished means they're still there. They're just diminished. So they're going to be absent. So you're going to have absent breath sounds. And they can be anywhere from that mild tachypnea to severe respiratory distress, right? So, one patient might just be breathing a little heavy, and you listen and you're like, oh God, there's no breath sounds at all. And then there might be another patient who's breathing super heavy, they're in respiratory distress, and they still have some breath sounds just absent at the bottom. So maybe their pneumo is not quite as big. It's going to vary patient to patient. So what are we gonna do to diagnose a pneumothorax? Chest x-ray. And what's it gonna look like? Has anybody seen one? It's black. It's completely black. Nothing there. So we have that spontaneous one that I talked about where you have the rupture of those small blebs, the little blisters. Usually, if it's a healthy young person, we say that it's just a primary spontaneous. So who is higher risk for spontaneous pneumothorax?
Older people?
No.
People with some kind of disease?
Young, skinny, tall males. Mm-hmm. And then,
we ain't got no race.
what's that?
We ain't got no race. That's young, tall, skinny.
Yeah, young, tall, skinny. And then if it's secondary to like cystic fibrosis or COPD or asthma or pneumonia, we say that it's a secondary spontaneous pneumothorax. Yeah, I said that it can be a primary, which means it's just a healthy young person. There's no reason for it to happen. It just happens. And usually they're skinny, tall, young. But if it's secondaries like COPD or asthma or pneumonia, then we say it's a secondary spontaneous. Uh-huh. So it does run if there's a previous family history, but usually, again, it's the tall, skinny, male.
Not legal to drink.
No, usually it's like late teens, early 20s, yeah. The first time it happens, and once you have one, you're more apt to have another. So, smoking will increase the risk. Obviously, COPD, emphysema, those things increase your risk. What does iatrogenic mean? So that's usually secondary to some sort of medical procedure. So the doctor's going in to put in that central line and they puncture. Or they go in to do like a paracentesis and they hit the lung. Or a thoracentesis. Barotrauma from ventilators. If the PEEP is turned up too high, it'll actually cause pneumothorax. Apparently, way before I was even a nurse, Miss Anderson likes to tell the story because she was an ICU nurse for years that everybody's PEEP used to get turned up super high, and now we keep it like between 5 and 10, I think it is. And you guys will get that during the ARDS lecture. But then every patient that ended up on a ventilator ended up with a chest tube because they were just, everybody had pneumothoraxes from the PEEP being up so high. So it can cause it, and now we're very conscious of that. Any sort of esophageal procedures, when they're going in doing like a TEE or an EGD, that can cause a pneumothorax.
Are those expected, or?
They are not expected. I mean, that's like, you know, when you go into surgery and they have to give you the worst case scenario type things. I think that the most common one that probably happens is probably during like a CVAD insertion, the central venous catheters. I think that's probably the most. I don't think it happens as often anymore with the like the barotrauma from the vents or anything. When we talk about the traumatic penetrating versus traumatic blunt, we kind of already talked about it. So the traumatic penetrating would be like a stab wound, sucking chest wound. So your patient's been stabbed and you walk up into the scene, and every time they take a breath in, their wound like is actually a sucking. Like if you look up sucking chest wound, there's some pretty raunchy videos. I love watching that kind of stuff. So you can find some pretty cool videos of sucking chest wounds. There's one video, and it was a little girl that was like attacked by a dog or something, and hers is just so obvious. But so if that happens, you cover the sucking chest wound with what? Yeah, so 3 sides, so it has to be occlusive, but only 3 sides. So occlusive is the same thing as non-porous, right? Non-porous and occlusive, same. But we're only going to do 3 sides because we want the air to be able to get out, but it won't be able to get back in because when they go to breathe out, breathe in, it'll form a suction. What's that? So no, because gauze is penetrable, right? So this has to be air can't get through. So I mean, if it's an emergent situation, you're covering it with whatever you have there, whether it be like a Ziploc baggie or a glove or anything that you can get 3 sides taped that when they suck in, it's going to cause a suction and the air can't get in through it. So. Thank you. If your patient comes in and they have a traumatic penetrating wound of the knife is still in there, they fell from the 3rd floor at a house site and they have rebar sticking through their abdomen, we do not remove that stuff. We leave it. Find it where you find it, right? That's right. That's what you guys do. Keep it right where you found it. But in the ER or on the floor or wherever you guys come across these patients, obviously it wouldn't be on the floor if you're working in the ER, we are not removing that. You simply are going to get some vital signs, question them, do a head to toe, but the doctor is going to be the one to deal with any of that. Yeah. I think we're at a 20 here. Yeah. So the traumatic blunt is obviously closed. So let's say that you are walking down the street and you get jumped and you get a baseball bat to the ribs, right? Your rib breaks and punctures your lung. So that would be like a traumatic close that would cause a pneumothorax. Okay? So it's something still opening that pleural space and allowing air in, whether it be from the inside or outside. And obviously if it's closed, it's going to be coming from the inside of the lung. So this is that tension pneumothorax that is the deviated trachea. So anytime you ever see a patient in a question anywhere on any test, our test, ATI, NCLEX, anywhere, or you see your patient walk into the ER and they have an obviously deviated trachea, pneumothorax should be the first thing you think, right? So it can be open or closed. It can be secondary to maybe you were doing CPR, you broke a rib, it punctured a wound or punctured a lung. It can be a motor vehicle accident, again, broken rib or open. It can be secondary to a clamped chest tube. So this is why when we start talking about the chest tubes, we say do not clamp them and leave them clamped. Unless it's ordered by the doctor, we never clamp a chest tube. So air enters the pleural space. So just like in that first picture, you have the pleural space and the lung is up here. But the thing with the tension is the air just keeps building up in there. So the more it builds up, there's no place for it to go, right? So now it's pushing, let's say it's this lung. Pushing. Air is building up, everything's pushing this way. That's why you get the deviated trachea. But what else is over here or here, right here? Your heart. So what's happening if your heart, you have all this pressure building up and it's pushing on the heart and compressing. It's compressing it, so it can't expand to pump, right? So not only now do you have a patient that can't breathe, but now they're not even being able to pump, so their cardiac output's down, and so then it leads into this whole other thing. So obviously this is an emergency. as a nurse, you will not be doing this, but maybe as a medic out in the field, you would be doing it when they do the needle decompression. So they put the needle in, and it just, and the air comes out of the blood. And, but it decompresses and it allows the lung to open. I don't know if the lung opened back up, but it lets the air out so that the whole chest cavity can move back to where it belongs. What do you think your patient's going to look like if they have this tension pneumo happening?
Like they're suffering.
Like they're suffering, maybe. So they're definitely going to be dyspneic. Their heart rate's going to be up because it's trying to compensate for not being able to pump the blood, right? So now it's going to say, well, I need to pump faster because that's the only way I can get the sufficient amount of blood out. You're going to have the deviated trachea. You're going to have no breath sounds on that side. If it's done in the field, the needle decompression, the patient pretty much has bought themselves a chest tube the minute they walk in the door at the hospital, right? If they come in and they notice it then they'll probably just do the emergent chest tube, get it in there and release it. So there's different types. We have the hemothorax and the hemopneumo. So what do you think a hemothorax is? Blood. So instead of air in the pleural space, blood has gotten in there. So that's more likely if you have like that rib fracture that's gone in and punctured the lung, stab wounds into the area, gunshot wounds into the area. So when you guys see your chest tubes at the hospital, sometimes there's a whole lot of like dark red blood, but then as it starts getting over, it turns more to like the serosanguinous type blood. And then it kind of slows down. But that's usually, almost always when you first put in a chest tube, even if it's not a hemo, you're going to get some blood just from if anybody has seen a chest tube put in, it's pretty gory. I have a video of it somewhere. I think it's actually linked into the PowerPoint that I put in there. But again, you can Google or YouTube it. I personally never want one. It's pretty nasty. So the hemothorax is the blood in the pleural space. Again, the treatment's just going to be the chest tube. And then, depending on the hospital and the equipment they have, sometimes it's kind of like, has anybody had like a ortho surgery where they have the drain and then they reinfuse, or doesn't you work ortho, so you know how we have the drains from the total knees and stuff, and we'll reinfuse for the first 4 hours or whatever it is. They can do the same thing with the certain chest tubes where they can reinfuse if it's a hemothorax. Hemopneumo, it's just air and blood. In your book, I think it talks about the chylothorax, and that's just like lymph drainage, like it's thick white. Yeah. So collaborative care for any type of pneumothorax is going to depend on the severity. So if I do an X-ray and my patient has, just a slight pneumo, I'm probably not going to put a chest tube in as long as the patient's not short of breath and having other issues. Usually they'll resolve on their own if it's just small. Obviously, they'll be doing chest X-rays probably daily to make sure that it's resolving. If not, then they'll buy themselves a chest tube. Otherwise, they'll have to do the thoracentesis if there's a lot of fluid in there. Sometimes they'll do the thoracentesis to get some of the fluid out, and then they'll put a chest tube in. Now they have the little pigtails where certain conditions will cause fluid to just keep accumulating, and so especially with the hospice patients, they'll usually just put a pigtail in there, and like once a week the nurse goes in and drains it and gets rid of it, and so it just keeps them from having to go into the hospital weekly and get stuck and have it done again and again and again. Yeah, it's like a tiny chest tube that the patient can go home with. Yeah.
You have a plastic bottle.
Is that with the bladder thing that was on the blue page? We were describing one time.
Yeah, I think you guys saw them, but I didn't see it. What do you mean a bladder?
So it was done surgically, and then the tubing was just on the outside.
Yeah. So it's actually in the pleural space. Yeah, and there's a little container, jar, that you just hooked up to it to drain it. What's that? It looks more like a JP. Like some of them look like little, like football-shaped ones. They all last week saw one
So
in.
it would be just a tube sitting on their chest, and then the container that the food is going to go in has a vacuum in it already.
Right, so it's like a vacutainer.
Yeah, you push
So-
down real hard in it.
Right, and usually you just have an order like to take off 1,000 or until it's empty. They'll do the pleurodesis if it's somebody who keeps getting recurrent pneumothoraxes. So let's say the only one I've only ever seen one person get it, and this person was
What's it called? A
pleurodesis, and she was probably in her 70s. She had COPD, emphysema, all the good stuff, and she came in with a collapsed lung, chest tube, re-inflated her, everything looked good, took it out, happened again. So what they do a lot of the times is they'll say clamp it for 24 hours. If they feel that the patient has completely re-expanded, nothing's coming out anymore, chest x-ray looks good, they'll say clamp it for 24 hours and make sure the patient's gonna tolerate it. So they'll clamp it, because that's the same thing as taking it out, right, once it's fully expanded. And then if the patient doesn't have any signs or symptoms, they'll take it out the next day or maybe later that day. But otherwise, if the patient suddenly starts, I can't breathe, I'm feeling short of breath, they'll do another chest x-ray, and if it's starting to expand, they'll just unclamp it. But the pleurodesis is, let's say they just can't get the person to either stay open, or this is their 6th time in 6 months that they've been to the hospital with one. They go in and they actually, between the lung and the pleural space, they'll create scar tissue. And so the lung basically gets stuck to the pleural space and it can't collapse. So they'll use talc with it's almost like a chest tube, and they inject talc into the pleural space. Or they'll go in and they'll use, it's almost like a sandpaper type thing where they just go in and rough it all up, and it causes the lung to adhere to it. Like it causes adhesions basically. And so that's a pleurodesis. I've only, like I said, one person ever that has needed it, but I'm sure they're done in certain units more than others. Pleural drainage and chest tubes we just talked about. Removes the air or fluid from the pleural space, reestablishes that negative pressure. It's about 20 inches long, and it can be real tiny, which is the pigtail, so like the 12 French all the way up to like a 40 French. So why do you think you would use one as opposed to the other? Like in sizes, why would you use a bigger one? Yeah, if it's blood, because I mean the blood's coagulating in there, it's thicker, or if it's pus in there or something that they're getting out, it's going to be thicker, so they're going to need the bigger tube. If it's just fluid that keeps accumulating, with like those patients that on hospice that we send them home with just the little pigtails because it's just some fluid that drains out. So that's going to be the difference in the sizes. Bless you. Yeah, so that's that video. You guys have the link to it. You can watch it. We just watched the insertion. So we're going to talk about the actual chest tubes now. So there's a couple different ones. There's water suction and dry suction. Regardless if it's water suction or dry suction, there's still going to be water here in this chamber. So this one's water suction, has a water chamber all the way over the side. This one has the bellow, so the dial, so that's a dry suction. So that's, looking at these, the only difference between them. This one has the bellow in the round part. This one has where the water is going to go for suction. So the suction on the wall is not going to actually make any difference in how hard it's suctioning the patient, you know, the stuff out of the patient's lung. It's actually the water amount in here that's going to. And usually the order is going to say -20. So the same thing, we would turn that to -20, or we would just fill this up to the line that says 20.
So if you see that dial, it's dry suction, it's the
Right. But regardless, they're both going to have water in this chamber. So in your book, the 10th edition book, and this is a change too, they call this the air leak chamber. We used to call this the water suction chamber, or the water seal chamber. But the new book calls this the water seal chamber. So one of the big things that we always push on you guys is that you do not want bubbling here in this chamber. So if we give you a picture and it has this chamber, this chamber, this chamber, this chamber, where do you not want to see suction or water bubbling? Here. So you will see water at the very beginning when you first put it in a chest tube. It's going to be some bubbling, and that's going to be the air coming out. Because remember, this is attached to your patient, right? This part. So whatever's coming out is coming out into this first chamber here. Anything that's liquid is obviously going to drop down to the bottom of the chamber. So this is where your blood's going to fill up, or your serosanguinous fluid. But the air, the top of these three chambers are all open to each other. So the air is going to pass through, and it's going to come down, and it's going to come through here. So there's a little hole, and it's going to come into this chamber. So this water in this chamber is what's keeping the air from being able to go back into the lung. So the air is going to come out, bubble through the water, and escape. And it's going to, the water is what's keeping it from going back in. So this is essentially your water seal chamber, because once the air bubbles out of the top, it can't come back in. And there's a little valve that it gets out. Okay? That's okay. In this chamber, you don't want to see it like bubbling. There has to be water in here. It should be up to the little blue line.
But you'll initially see
You'll initially see some bubbling. If the bubbling completely stops, it means that the lungs probably re-expanded or your tube is clamped somewhere. So, did you guys hear that? If there's bubbles, and then suddenly there's not, I mean, you're going to see some bubbling, especially at the beginning when the air is coming out of the lung. But then after that, you're going to see some tidling here. So every time, you know, they breathe in and out, like if they're on that video, you're going to see the water here going up and down. If you see bubbling though, and then all of a sudden there's just no bubbling, or the bubbling has stopped completely, it's because the lung has either re-expanded or this is kinked somewhere. Okay? Yep. If there's, no, you're still going to have some movement here every time that they're breathing it out. Or actually, if it's kinked, then you wouldn't. Yeah, if it's kinked, you wouldn't. But if there's no bubbling at all, that means that either the lung has completely re-expanded, you still have some tidling, but there's no bubbling, or it's kinked.
Well, I think if it re-expands you, that's a good thing, right?
You will have some
Or it could be a bad thing when it's heat.
Okay.
That's why I said your patients when you're so bubbly. Yeah, basically.
Figure that out.
Usually it's looking at
Suction
you
pulling.
system.
So this would end up bubbling like crazy. So if there is all of a sudden this is bubbling like crazy down here, and you see in this chamber down here, then you would start working your way from the chamber up to the patient, or from the patient down to the chamber, whichever way, and looking for some sort of leak. So you'll see a lot of times these, anytime, like if they have this expanded to a longer one and they have them coupled together with this one, the nurses put tape around it and stuff, and that's just to keep it from opening, keep the leak from happening. This, you don't really want to tape it, because this is where if you need to replace one of these, Alero got to do it the other day. We had a person who apparently had fallen on the ground several times, and I just kept picking it back up, so none of the numbers were where they should be. So Alero got to disconnect it, reconnect it. And that, the only time that you're really going to clamp it, unless you have that order to clamp it for 24 hours, you would clamp it just to unclamp this, to get rid of this, to put the next new one on. Right? up to 2 centimeters of water.
Yeah.
And just make sure that you have some movement or something's happening so that you know that it's connected. Put the suction back up. It comes with sterile water. So this is not a closed, completely closed system. The air comes out, the suction's, pulling, so there's air moving through it. So you're gonna have some evaporation. Especially if for some reason you walk in, and it's funny, because a lot of nurses, we see them a lot on the trauma floor, but because we're on the trauma floor, a lot of times you'll see nurses that have them and they haven't had one in 3 years. I don't know, I haven't had a tube in forever, I guess it's literally. You walk by the room and it'll sound like a hot tub, like all the bubbling. And you're like, what the heck? It shouldn't sound like a hot tub, because if this is bubbling like crazy, that just means that they have the suction current way up on the wall, and all that's gonna do is evaporate the water. So as that water evaporates, you need to keep adding sterile water to it to keep it economy. Yeah.
So it's sucking the air into your cavity, right? So once the lung is fully inflated, would it automatically stop?
It won't automatically stop, but there's no air for it to suck, so it wouldn't, it doesn't hurt the lung, it doesn't. But you would have this, the bubbling here was not.
Okay, it's still sucking air from that system. Would it suck part of the lung?
No. It's not sucking hard enough to do that.
Twenty.
Right.
Mercury. That's pretty high vacuum.
Yeah. So, no, it doesn't run anything. So, when this stops bubbling though, and the patient, you can hear lung sounds now, everything sounds good, the doctor will tell you to clamp it, or they'll come in and just get an X-ray and pull it, depending on the doctor.
Does the water prevent the air from coming back in?
So the water in this chamber prevents the air from coming back in, because the air comes down and comes out, so once it bubbles out of this, it can't come back in. It creates a seal, so that's why we used to call this the water seal chamber, but your book now calls this the water seal chamber. So, I know, you're getting to change things on me.
And you can't clamp it unless you have doctor's.
You don't ever clamp it unless you have a doctor's order to clamp it. So your patient's going to x-ray, we're not clamping it, right? We're just gonna give the tech who comes to get him, we're gonna say this needs to stay below his lung, just like a Foley, right? We don't want it above the lung, just like we don't want a Foley above the bladder. So a couple things can happen. So let's say your patient's laying in bed and they get real restless and nobody's watching the tube, because technically that tube, so this should be on the floor or hanging lower on the bed. It never should be on a part of the bed that moves. When the bed's raised and up and down, so it should be in a stable area. You shouldn't have dependent loops, meaning that this should not be like coiled on the floor where it's laying on the floor and everything's just laying in there, because then there's no gravitational pull happening. So this should be on the floor, and then technically the chest tube should be on the bed, coiled up next to the patient. Ms. Patterson earlier was saying that it's really funny because when you get these nurses who haven't had chest tubes in years, she likes to tell the students, go in there and, put it the way it's supposed to be put, and then just hang out in there for a little while. She says, because then the nurses come in and they're doing their assessment and they get down on the floor, and then the students coil it back up the way it's supposed to be, the nurse comes back in and pulls it back down on the floor again. I don't know why, and I think honestly, like a lot of people just, if you don't use it, you lose it. So you haven't had it in a while. So yeah, this should be on the floor, lower than the lung. This should be coiled on the bed so that it's actually draining down, so there's no dependent loops. If for some reason someone goes in, the patient's rail is moving around, this gets stuck in the bed rail gets put down, this gets pulled out of the patient's chest. What are you gonna do? 24 hours. It stays on. If it starts leaking at all, we just reinforce it. We don't take it off, and then obviously we call the doctor. And then after 24 hours, usually it'll come off. They don't usually suture up the hole and heal on its own. It's usually pretty tiny. If it is a bigger, like 40 French, I'm assuming at that point maybe there'll be some glue or something, but it usually kind of like heal on its own. So usually 24 hours. Right. So again, it's depending on the patient and how hard it gets pulled, like, how it actually gets pulled out. Again, was the patient almost completely healed? Did it actually do a lot of damage? So let's say now this is still in your patient and somehow the tubes were connected together and they got pulled apart. So now you still have, this one going on your patient and it gets detached completely. What do you think you do?
Reattach it?
You don't reattach it because now chances are that the part that detached from your patient is falling on the floor, right?
Yeah.
So if you pick that up and reattach it and somebody sees you, big trouble. Yeah, don't do that. So,
That's right, because there's a sterile procedure to do the dressing change, which is, I think, the hardest part of the job, right?
dressing change now isn't sterile.
Oh,
Clean.
I do it sterile.
So if it does become detached from the actual chest tube and it's still in your patient's chest, then you take the end of the part attached to your patient still and put it into the sterile bottle of water, at least the 2 centimeters, because now that's acting as your seal. It's not letting air back into it. So what's going to happen if we don't reattach it? Every time they breathe in, air is going to be getting right back into that pleural space and end up completely collapsed and possibly with a pneumonia. Yeah. So normally, this is much longer. Usually it's like 2 of them attached together. And so let's say something happens, the one that's attached to your patient is still there, but it gets detached from here, from the container. This gets broken or pulled off, or suddenly there's a crack in here. So you take it off. You usually would have a small bottle of sterile water bedside, and you should have a small bottle of sterile water bedside. So you would put it into that sterile water. So that's still going to allow the air out, but no air will be able to get back in. So you don't want to clamp it, because by clamping it, you can actually cause a pneumothorax, because it's not letting the air out. So every time they breathe, instead of the air coming out, going to the water, it's just building up in there, and that pneumothorax, or the pinching. Well, this would still be in, the dressing's still there. It's just disconnected over here somewhere. Let's say somehow this is connected and that gets knocked over and this isn't touching this area. So stick it in the sterile water. That way the air, when they're breathing, the air is still coming out, but that sterile water is preventing it from getting back in. So if I clamped it instead of putting it in the sterile water, it wouldn't let the air out. So that would cause a pneumothorax. Okay? Yeah. Yeah, so this fell on the floor and it's in your patient and like there's no other connections anywhere, you would still stick it in the sterile water because you still want to prevent the air from going back in. And then you would have to call and you would have a very unhappy doctor. They'd have to go in and replace it, yeah. I mean, actually, no, they wouldn't.
You just get
Because it should be close enough to the patient. There should be another small one that this is connected to. So hopefully they would just be able to go in and replace just the tube. Yeah.
Also, the one that goes inside the patient has like a small piece
Right.
sticking
And
out.
then this should be attached to that.
A permanent one.
Right. So the only way that then they'd have to redo the whole thing would be if somehow that.
But whether it gets, in this situation, whether it gets or not, obviously we want to stick it in that sort of sterile
Yeah.
water.
Still in your patient, disconnected from the Same thing with this thing over here. Instead of filling up the water to 20, you would just turn the dial to 20.
I'm guessing 20 is the average.
Yeah, that's usually what the order is. If you haven't seen a yellow Xeroform, I love the smell of this stuff. I don't know why. But it's just the petroleum dressing. If you haven't seen it and you want to see it, it's over here. It does. You know, my husband has a palinatal cyst that acts up, and he had to have it drained once. And you know the iodoform, the gauze, the roll of gauze inside the jar, the brown jar, has a very distinct hospital-y smell. And so he had to have it packed and stuff. So now, like, I have a bag of hospital stuff, and that's in there. And if he even smells it, he like gets PTSD so bad. He hates it. He can't smell it. It's so funny. Okay, so again, this is your water suction pleural drainage, and I have the areas there marked out: water seal chamber, water fill suction chamber, water leak monitor, and then the collection chamber. Same thing with your dry suction, except instead of that water filled suction chamber, they have that bellow and dial. Still going to have the 2 centimeters of water in the bottom. Still a one-way valve. The bubbling still equals an air leak. Everything else is exactly the same. Nobody's going to ask me why you use one over the other, because everybody always asks that. Why do you use one over the other? And I swear to you, it is doctor preference. And they are going to tell you, and it's probably like, so-and-so went to this school, and this is what they used. But we always have both. In stores, they're always down there for whatever the doctor wants. Huh? You did? Yeah, that's what happened the other day when we were up there. All right, so nursing care management. So your responsibilities are, you're going to prepare the unit and add the water. So before you connect the patient to the actual chamber, and sometimes if you're working in the ICU or the ER, these are being done bedside emergently, so you're going to be there helping the doctor do them, right? Sometimes, depending on the hospital, they're done bedside regardless. So you would get the chamber, you would make sure that you have that sterile water that comes with it in that seal chamber before you connect the patient. So you need to maintain patency. So make sure that any of the connections where they connect together, I would tape it. Make sure that the tubing is coiled next to the patient, not on the floor, because you don't want the dependent loops. So you're going to observe for titling. So that's that one chamber. When they breathe in and out, you should see the water rise and fall. Remember, you might have a little bit of bubbling at first in that chamber C. But as the pneumo resolves, the bubbling will stop. Or if you have a kink in your tubing, you'll have no bubbling. You need to assess your patient status, obviously. So we want to make sure that we're getting vital signs, breath sounds, assessing their pain. You guys saw the insertion on that video. I would think for at least the first 24 hours, it's going to probably be pretty painful. No, usually it's just gauze. Like the Xeroform with gauze. I mean, you can see it pretty much except for right around it, and if it's going to be red enough and draining, you're going to see that. Drainage amount. So at the beginning of your shift, when you're doing bedside report, make sure that the nurse that's leaving marked where her drainage was with her initials, time and date. And then at the end of your shift, you're going to do the same thing. And that way, there's a couple different reasons. The doctor can go in and just see how much drainage has been since the beginning of the shift. You can keep track. So let's say the last 3 shifts, they've had 50 cc's out, and then suddenly on your shift, there's 500. There's obviously something wrong, right? So that would be like a stat call out to the doctor. Anything more than 100, you have to worry about. Well, I shouldn't say that, because if it's a brand new chest tube, you might have 100. But if over the next few days it starts dwindling down, and then suddenly, like I said, you're getting more and more, anything over 100, I would call the doc. Per shift, yeah. I mean, like I said at first, if it's coming out, you know, there's 100, 100, 100, 90, 80, like that's okay if the trend is following. But if suddenly it's been 50, 50, now it's 100, I would have somebody check that. We don't want to pull too much, right? So if suddenly you have 600, or even at the very beginning, if you have 600 out, I would probably let the doctor know that too, because how much is 600 cc's? It's a lot.
Can't be over 100.
Right, that's what I said. If it's 100, I would call the doctor. But if it's like way more than that, what are we worried about? Yeah, so hemorrhaging, we're pulling a lot of stuff off, so shifting of the shock, yeah, hypovolemic, right. So make sure just for yours and your peers that you're writing down the amounts and the dates and the times. That way we can kind of keep track of where it's going. And now with the computers, you know, you're supposed to document every shift anyway, or every 4 hours, how much output there is. Oh, what's sub-Q emphysema?
What is the bubble on the skin?
Yeah, so there's air that gets trapped under the skin. What does it feel like? Rice Krispies. So one of my students a few semesters ago actually got to feel it up on 5 South because the patient had chest tubes and he had just come in and they were brand new and the air was trapped under there. And usually it resolves on its own, but when you run your hand over it, it pops like Rice Krispies. Yeah. So you want to assess your patient for that. Encourage incentive spirometer and range of motion. So this can be hard, especially if you have the patient that has a pneumo because of a rib fracture. Because those rib fracture patients do not want to take deep breaths, which we'll talk about in a minute. But it's important that they do, just to keep the airway open, right? To get that lung to re-expand. So again, we are not going to clamp this unless you have a doctor's order because they're getting ready to DC it. The other 2 big things that we say do not do is milking and stripping. You guys know what that is? Okay, so stripping would be like if you hold it here and you pull it down like this and then you let it go, and basically it raises that pressure from negative 20 to 400. So it can cause a pneumothorax, it can pull out pieces of tissue. Because they're trying to get a clot out of the tube or something. If for some reason you really just can't like do this and get the clot out and get it moving, then you should just replace the tubing. Or otherwise, like you'll see people like milking it, so they'll do this to try and get the clots out and milk the clots down. We don't do any of that because it increases the pressure and can cause a pneumothorax. Stripping, yeah, basically. So. Yeah.
So what do you do if it's clotting too?
If it's clotting and there's really nothing happening, it's completely closed off, you have no bubbling down here at all, and it's not draining, then you would just change the system out. Huh? Flick it? You can sit there and flick it if you want. I don't know if it'll do anything.
I think that's what I need to.
The other thing is, so last semester one of the nursing students was like, so I was with an old SPC student in ICU, and she kept saying to me, don't do this. This isn't according to Lewis. This isn't for your test. And one of the things was the doctor went in and told her to strip the tubing. And so she's like, what would you do? I said, honestly, I would tell the doctor to strip the tubing if he wanted it stripped because my license costs me too much and I don't ever want to be responsible for hurting somebody. So, you know, if he's comfortable doing it, he can do it. Or if the charge nurse wants to do it, she can do it, but I'm not going to do it. So I would just stick to your guns on things you're not comfortable with. There's always, you know, if he yells and screams, bring on the AOD, go ahead. You know, it's just stick to it. Someone else can do it. So no milking, no stripping, no clamping. Make sure that it's not elevated above the lungs. So if your patient's in a wheelchair, getting ready to go down for their chest x-ray, we do not want it hanging on the back of that chair, right? Don't want the coils tubing up here hanging on the back of the chair. Well, if the patient's with it enough, they can just kind of hold it down next to them. They can, you know, hang it between their legs. I don't know. There's always something they can do. So we never empty these. The whole thing gets changed when it's full. There's no, like, you don't have to change it every 3 days or anything. So it would just be changed when it was full or when it got kicked over. So all the measurements are off now. We don't know what was from when. You would change this big chamber. So again, you would just disconnect it. You would clamp it, disconnect it, get the new one. You'd already have the new one set up with the water in it and everything, and just reconnect it. It would be put into the biohazard bag. We don't empty it. So it just gets put in the red bag and gets put into the biohazard trash.
Is there like a standing order for that then? You said you can't clamp it without that.
It would be clamped for a second.
Oh, okay.
Like literally, you would get the other one set up ready, clamp it, disconnect it, reconnect it, unclamp it. Like maybe 5 seconds. So when it's full, when it gets knocked over. So if you do happen to walk into a room, and sometimes you'll see the nurses get tape and they tape these things down to the floor even to try and prevent them from getting knocked over. But if, let's say you do knock it over, get it back up as quick as you can and take a look at it, because if everything still looks okay, then you're good to go. But you need to make sure that you still have your 2 centimeters of water in here and that, you know, nothing got kicked over into other chambers. And if they did, I would just change the whole thing anyway. Complications, re-expansion, pulmonary edema. What's that? Yeah, so it can happen if the fluid's taken out too quickly. Like it'll just, the fluid will just come right back. Some cutaneous emphysema, which we talked about. That's the air leaking into the tissues. So with the air leaking into the tissues, usually you're just going to get that little bit of sub-Q emphysema. But what happens if the leak is large and it just keeps happening, and now suddenly, like, your patient, you notice that they're doing this because they're swollen up here now even, right? I'm not doing that. But I would call the doctor or whoever's on call super quick. Make sure. So we see a lot all of a sudden dressings that aren't dated and timed and no initials, and so you have no idea. They've been there for 3 hours, 3 days. I don't know. Make sure that you guys are putting times and dates and stuff, because they might not say anything to the nurses, but they will always pick on the students and call us out on it. So just make sure you guys are doing it. If it's overturned or the water seal is disrupted, again, we're going to change the whole unit. If the CT disconnects from the chest, what did we say? 3-sided dressing or a gloved hand until you can get a 3-sided dressing. Good. And if it disconnects from the chamber? Sterile water until we can get the new one back up, right? So removals, Usually once the lung is re-expanded, like I said, the doctor will either ask you to clamp it and do a chest x-ray. Sometimes they'll wait to make sure that the everything looks good after we clamp it. Sometimes they'll just take it out. The nurses never take it out. Sometimes there'll be a PA or NP that'll take it out. We usually try to pre-medicate them. I mean, as much as it hurt going in, I can't imagine that it tickles coming out either. So try and get some pain medication on board first. Have them bear down as they're taking it out. And then we're going to put that occlusive dressing on there. And then obviously we're going to be monitoring the patient for any sort of respiratory distress that happens. If they start all of a sudden, they're just like, I don't know, something doesn't feel right. I just feel like I can't get a deep breath. Definitely call, get a stat chest x-ray because it might be happening again. So rib fractures, the most common are going to be ribs 5 through 9. And it can damage the pleura or the lungs. What's your patient going to look like walking through the door with a rib fracture? Yeah, they're going to be splinting, something wicked, right? They're not going to be taking deep breaths. They're going to be very shallow respirations. So we used to splint them. I don't know if anybody remembers that, but we used to take ACE bandages and we would wrap them super tight, right? So what happens when we do that?
They can't breathe.
Can't breathe, chest's not expanding, what's going to happen? Pneumonia. They're going to end up with atelectasis and pneumonia, right? So we need to make sure, as much as they do not, are you guys looking for it in the book? It's back in a different chapter. Like, oh, it is the same chapter? Okay. $520-ish. 521. As much as they don't want to take those deep breaths, we need them to. So we're going to encourage them to deep breathe and use the IS, and they're going to hate us. And obviously, we're first going to try and give them some Tylenol, but it's pretty painful. So sometimes we might work our way to some opiates or even a nerve block, depending on what's going on with that patient. Flail chest. Has anybody seen flail chest?
Yes.
Videos, yeah, it's pretty cool, right? So if the patient is awake, they can, even without holding it, like their body is going to do a pretty good job of guarding it. Like they're going to tense up enough that it's going to guard it and it's not going to be as easy to see. But if your patient is either knocked out or under anesthesia or something, it's really, like, it's pretty cool to see. So what happens is we call it the paradoxical movement. So usually, let's say I take a deep breath in, my chest expands. So a flail chest is two sections of rib, or two parts of the rib broken, so it causes like this free floating section. So as I would take a deep breath, my chest would expand, but that section actually goes in. So it's like this paradoxical movement that happens. Look up a video of it, it's pretty neat to watch. So basically you have several consecutive ribs in two or more places that are separated. So you get this unstable fragment. So up in the picture there, it shows 3 different ribs, 3 with sections on both sides. So that section of the 3 ribs that are not attached would be your flail chest section. So again, with these patients, they're going to have inadequate ventilation. They're going to have increased work of breathing. They're going to have rapid shallow breathing, increased heart rate, definitely some crepitus. Diagnostics, they're not going to want you palpating it, but if you palpate it, you'll be able to feel that crepitus and feel that the bone is broken. They're going to have abnormal respiratory movements, so again, that paradoxical movement. Chest x-rays, ABGs, depending on how long it's been broken for and they've been, trapped somewhere. Let's say this is your person that's trapped under the building that collapsed 3 days ago, and now you're just getting to them, right? So their ABGs are going to be off completely because of that impaired ventilation. And we're going to go over ABGs in a couple weeks. So what about treatment? Surgery most of the time. So it depends. So we're obviously going to do some sort of airway management, especially if they're really having a hard time breathing. They'll ventilate them. Obviously, some oxygen, IV fluids, pain control. So if we can get the pain under control sometimes, you can get them to calm down a little bit. The breathing will return to normal, and you can get them back into like a regular ABG. Surgical fixation. So usually they'll go in and they'll put the plates on either side with the screws. So when we talk about any sort of chest trauma, the emergency nursing assessment, obviously we're looking at respiratory distress first and foremost. So we're looking for any sort of dyspnea, coughing, cyanosis, tracheal deviation, decreased breath sounds, changes in the SpO2, and then if they have any sort of bloody sputum or frothy secretions, it's never a good sign either. And then we also have to worry about any sort of cardiovascular compromise, so rapid thready pulse, decreased blood pressure, JVD. Muffled heart sounds, dysrhythmias. So your two priority systems anytime that there's chest trauma is going to be your respiratory and cardiovascular. As far as interventions, what's always first? Airway. Patent airway. We want to make sure that we have them on oxygen and we're keeping their oxygen greater than 90%. Want to make sure we have IV access. Really, every patient coming through the doors of a hospital should have IV access just in case. We want to make sure that we get the clothing off so we can assess the injury, because sometimes there'll be an injury that we don't see just from looking at your patient. If they have that sucking chest wound, we're going to cover it with 3-sided occlusive. If they have a bullet wound, same thing, 3-sided occlusive or occlusive. If they have, again, a knife or a rebar or something sticking out, we're just going to pat it and keep it, we're going to bind it so that it can't move because we don't want it to do any more damage, right? But until the doctor gets there to assess it, we're just going to keep it where it is. And then ongoing, we're just going to be monitoring the vital signs, pain, LOC, oxygen levels. So that was our chest trauma. With abdominal trauma, our mechanism can be the same, blunt or penetrating, right? So baseball bat to the belly. Or back. So with the organs, we have solid organs and we have hollow organs, right? So with our solid organs, so what are, name a couple solid organs.
Liver.
Kidney, spleen, right. So those are going to bleed, right? So we're really worried about bleeding. Who had the lady the other day that had the splenectomy? She was in the car accident. Was it you? She had the splenectomy. They had to go in and she had the chest tube. Yeah. So in her chart, when we were looking at it, they were talking about the massive amount of blood in her peritoneal cavity from the spleen being lacerated. So with our hollow, so like our bladder, we're more worried about the internal contents of those hollow organs spilling into the peritoneum and causing peritonitis. So again, we can have abdominal compartment syndrome. These pictures up here are the Cullen sign. So that's blood around the belly button. So that is a sign of what? What do you think? Yeah, internal bleeding in the abdomen, right? So have you heard the term retroperitoneal? So it's the backside. So you'll get more of like the gray Turners. So it's going to look the same. It's going to be bruising, but it's going to be back here on the flanks. So that's the gray Turner sign, and that means that you have some retroperitoneal bleeding. So your patient probably will be splinting and guarding. When you feel the belly, what do you think it's going to feel like if they have something going on in there and they have bleeding and pressure? That's when you hear about the rigid bellies or the board-like bellies. So it's going to feel hard and rigid. What about bowel sounds? Decreased or absent, yeah. What's that? Yeah, I mean, if it's distended and there's lots of air in there and the patient's guarding and there's not much moving around, it's probably going to be diminished at the very least. What's evisceration? Yeah, like when your organs are just kind of there, right? They're just hanging out, yeah. So if you hear evisceration, it's that there's some sort of very deep, penetrating injury that causes the abdominal contents to come outside. What's the difference between what? Yeah. What if you don't hear any bowel sounds down here, but you hear them really loud up here? Yeah, so usually that would indicate some sort of like rupture of the diaphragm, and the bowels have herniated up into the... Yeah, bowel sounds in the chest are not a good thing. I mean, don't get me wrong. Sometimes you can hear bowel sounds when you're listening to the lungs, right? Yeah. Patient's belly is growling. But this is completely different. So if your patient has abdominal trauma, we're going to get CAT scans, x-rays, ultrasounds. Right now, I think that the ultrasound is probably the one that you'll see done. It's quick. You can get the results super quick. You can see what's going on. You don't have to wait for the radiologist to come back and read anything. The peritoneal lavage, you're opening yourself up for infection, because what you're doing is actually putting like a liter of saline into the belly and then draining it back out to see how many parts per million of blood there is inside the bag. And that has to go to the lab, and then the lab has to go in and do the measurements. So I'm sure that they still do peritoneal lavage. And at that point, if you're suspecting that your patient has any sort of bleeding going on in the belly, you as the nurse are basically preparing to get that patient ready for surgery. So get consents. If there's family there, let the family know what's going on. Prepare the family. Maybe start talking to the patient about the possibility. So nursing care management for the abdominal trauma. pretty close to the other one, right? Patent airway, always number one. IV and fluids. The difference with this one is you're probably going to get an NG tube. We're going to want to decompress the belly. We want an NG tube. Again, those impaled objects are going to stay in place. So here's an interesting thing that happens with abdominal issues. If you go into the ER and you're like, oh my God, I'm dying, you're bent over, I have all this abdominal pain, I don't know what it is. They're not going to treat you with pain medication until they figure out what's going on, which seems like the devil, right? You're like in all this pain and they can't give you anything. But it's because you have to be able to react to the tests that they're doing, and that way they can see exactly where the pain is and what's going on. So these patients will not get pain medication until they figure out what's going on. We also want to make sure, again, we have stuff that could have spilled into the peritoneum. We're looking at peritonitis possibly. So we want to make sure that we are doing everything as sterile as we possibly can to prevent any additional bacteria from getting into this patient. We want to prevent sepsis. Really, that's with anything though. You know, for the last several years, that's been the big movement. The very first thing you're going to do when this patient gets in there before you do anything is vital signs, though. You want to make sure that they're stable hemodynamically before, you know, you even start asking them about pain levels or anything. You guys don't really need to know pelvic trauma. Just know it's easily missed, high mortality rate. Usually there's so many other things going on. If you have a patient that comes in with a fractured pelvis, they usually have lots of other stuff going on. And because they're laying on a bed, they're not really moving, so you're not seeing like everything's off kilter. But it can be really, like, there's a pretty high mortality because the bladder's right there. So if the bladder gets crushed, there's arteries there. So if the artery gets nicked, clinical manifestations, swelling, tenderness, deformities. But again, if you have a patient from a trauma and they have everything going on every place else, unless the patient's completely 100% naked, you might not immediately see the swelling or discoloration in the pelvic area. If for some reason there is pelvic trauma of any sort, you will not put a Foley in. You're going to call urology to come put it in, because we don't want to take the chance that there is a ruptured bladder in there. We're going to let them do that. With the fractured pelvis, this is the only thing that would really be different is that we would add in like a DVT PE prophylaxis, because it would be a bone fracture. You guys remember your 6 Ps from level 3? Not poikilothermia. Take that one away. It's your other 6 Ps. The limb trauma, again, you guys don't need to know too much about it. You guys got limb trauma in level 3. I know that because I taught it. Compartment syndrome, I think you guys probably learned about that at the same time. I don't really remember, but I know that you guys got it. The treatment for the compartment syndrome is what? Fasciotomy. So have you guys seen, I think the 10th edition might have a picture of the Jacob's ladder.
The F one is for the left limb, and there's another one for chest, right?
Chris has a picture of the Jacob's ladder.
There's another one for chest. Something else if it's the upper body.
No. But the Jacob's ladder is like, it's like a plastic thread, and they basically, it looks like a corset going up the leg. And then every day they'll bring them back into the OR, they'll debride it a little bit, they'll pull it a little bit tighter to close it up, and eventually they'll get it completely closed back up. I'm surprised we haven't seen it yet this semester up there. We usually do, but I think there is a picture in the book.
It's on eBay.
All right. So there is, in Winningham's, Oh, you know what? We'll just do the one. There's a couple of good case studies for chest tubes and stuff. We'll just do this one part. It's just a true or false with 10 questions, and then I'll let you guys go.